Okay, thank you, members. So we're now into our public session here for this morning's meeting. I want to welcome all of members who are participating by video conferencing and to remind members about the protocols regarding the use of electronic devices. So, are members aware of any apologies today? Clerk? No? Okay, thank you. Members, in terms of chairperson's business, I just want to flag up a meeting that the Deputy Chair and I did with terminally ill cancer patients here in the Assembly, in the Parliament buildings on Tuesday. The committee will be hosting an event on Monday the 7th of March at 11:15 a.m. in the Senate here to highlight those very real and very human stories behind secondary breast cancer. And there's an art exhibition has been put together with those women. And I have to say, members, it was one of the most harrowing, yet one of the most uplifting meetings I have done yet, I have to say, with members of the public here in the Assembly. I will maybe ask Pam to come in as well briefly on this. But I think it's something, members, it really brings home the human impact of this diagnosis, the human impact of trying to access services, the human impact of how people are supported or not supported in that very, very difficult time of their lives. And I would encourage everyone, and I mean all members of this Assembly, to view that exhibition, because I think it is important and a significant message that these women are bringing forward in very difficult circumstances. So I do see an indication from Paula, but I will go to our Deputy Chair, Pam Cameron, first of all, and then I'll go to Paula. Go ahead, Pam, please.
Thanks, Chair, and yes, I agree with you wholeheartedly. I think I did say to those ladies that we met that it was incredibly brave and a very selfless act of them to undertake the work that they're doing and to have been part of this exhibition, and it was incredibly powerful. And I was very much struggling emotionally, even with the presentation in front of us. So I do think it's really important that everybody who is able to attend that exhibition does when it comes to us on the 7th of March. I think it'll be a very powerful exhibition and something that we should see if we're able to, and understanding that for some people within the Assembly it actually might be quite difficult. But yes, incredibly powerful, and I would encourage everybody to make that effort and encourage their colleagues to make that effort to attend that exhibition.
Yeah. And just to say that the Health Committee are hosting and sponsoring that event and the exhibition, so just let members know that is us that's doing that. Paula, go ahead, please.
Thank you, Chair. Some of the ladies came back to me and we're very, very grateful for your and Pam's time. I just would, for those people who are actually watching online, I'd just like to say that the exhibition is also going to be in Belfast Exposed, an art gallery in the city centre from the 28th of April, I think, till the 3rd of May. So it will be open to the wider public, and I would encourage, I've seen their photos are very, very powerful, and I would encourage anybody who can't get this Stormont to get to Belfast Exposed instead. Thank you.
Thank you, members. So I would then also remind members that we are meeting concurrently with the Justice Committee today at 1 p.m. We will need to be concise with our questions during this meeting, members, and we need to stay on time to allow the committee to get finished by 12:30 today, to give members a short break before we go into the second and the concurrent meeting with the Justice Committee. So thank you for that, members. Draft minutes then. I refer members to the draft minutes of the meeting of the 17th of February at tab 3.1 of the pack. Are members content with those minutes? Yeah, thank you. There's one further issue arising from those members, and that is in relation to the Abortion Services Safe Access Zones Bill. At tab 4.1 of your table pack, there's a letter from Claire Bailey, MLA, sponsor of the Abortion Services Safe Access Zones Bill. The letter outlines a number of further amendments to the bill that the sponsor will be bringing forward following her discussions with the OLC. The letter outlines a number of significant amendments to clauses and amendments that the committee had already considered. If members are content, the committee can meet on Tuesday lunchtime to consider the amendments, and if the committee are content, whether or not to support those amendments. So would members be content that we do that? Yep, members content, thank you. And would members wish to invite Claire Bailey to brief us on those amendments? Yep, I think members content, yes. So we'll invite the bill sponsor to brief us on those. In relation then to the Adoption and Children Bill, the consideration of further draft amendments. So at last week's meeting, we considered an amendment to the Adoption and Children Bill that would change regulations in clauses 24, 52 and 77 from negative resolution to draft affirmative resolution. So are members content with that amendment, and that I move the amendment on behalf of the committee? Yeah, members content, thank you. Members, we have also received correspondence from the Minister providing further amendments to the Adoption and Children Bill. These amendments will amend clauses that the committee have previously agreed. Would members be content that we consider these amendments at our meeting on Tuesday to come to a position on those amendments from the Department? Yep, content. Thank you, members. Okay, members, moving on then to our first briefing this morning, which is in relation to cancer services and a briefing from stakeholders. This is the first of two briefings today on cancer, with representatives from Macmillan Cancer Support, Cancer Focus NI, Cancer Research UK and Marie Curie. A copy of Cancer Focus's manifesto for 2022 is included at tab 6.2 of your table pack. This will then be followed by a departmental briefing on the cancer services. So I would now like to welcome to our committee this morning Margaret Carr, who is Public Affairs Manager with Cancer Research NI. Margaret, can you hear us okay?
I can indeed, thanks.
Thank you, Margaret. We are also joined by Richard Spratt, who is Chief Executive of Cancer Focus NI. Can you hear us, Richard?
I can, Chair, thank you.
Thank you. Alistair O'Hara, who is NI Policy and Public Affairs Manager. Can you hear for Macmillan Cancer Support? Can you hear us, Alistair?
Good morning. Yes, I can hear you fine.
And Joan McEwen, who is Head of Policy and Public Affairs, Marie Curie. Joan, can you hear us?
Yes, I can. Thank you, Chair.
So I feel like we're a lot of us going from one meeting smoothly into another. I've seen quite a few of each of you over the past number of days, which is, I think, a reflection of the amount of work that's ongoing from yourselves in relation to these, and also the concerns around provision of cancer services and where they are at present and where they are heading to in the future. So I will invite the witnesses to make opening remarks, and if I can go back to Margaret, I believe, Margaret, you're going to lead on opening remarks, and then we'll potentially go then to members' questions. Thank you, Margaret.
Thanks, Chair. Securing the funding for and the full implementation of the cancer strategy is the #1 priority for Cancer Research UK, and indeed for all of the cancer charities represented here this morning. We are now in a situation where we find ourselves with no confirmed budget going forward. In several surveys, the public in Northern Ireland have identified health as their main priority, and the charities and all attending today want a commitment to a 3-year budget with a focus on health broadly, but most specifically, it must provide funding for the full implementation of the cancer strategy during its critical, its critical initial period. Cancer patients in Northern Ireland are experiencing delays in diagnosis and sometimes don't receive the optimum treatments. The strategy provides actions which will improve outcomes for patients. Actions including preventing more cancers, improving earlier diagnosis, giving more personalized treatment and care, providing the optimum cancer workforce, and data systems which can produce timely and usable information to enable better decision making. The strategy is the roadmap for the transformation of cancer services, transformation which is much needed and long overdue. As I said, all the charities represented here this morning are united in prioritizing the funding of the cancer strategy. We also all support the additional issues which will be raised by the other charity representatives as they speak now. Thank you.
Okay, thank you. Yep, so can I check then? I'll go to the order we have on my list. Richard, will you go to make some opening remarks as well?
Yes, Chair. Excuse me, and thank you for the opportunity to present and obviously support what's already been said by Margaret. Just to make a couple of additional points from a cancer focus perspective, given that the data in Northern Ireland is indicating that cancer incidence will double by 2040, It's going to be difficult to treat our way out of that with a continued insatiable demand on public finance. And from our perspective, we feel that cancer prevention, health promotion initiatives too often have been seen as a Cinderella. And in order to save money into the future as well as lives, we feel it's vital that health promotion and cancer prevention is front and centre when enacting healthy public policy. And there needs to be initiative, coordination and intention in that regard now, not in years 4, 5 or 6 of a new strategy. And there are a number of specific actions which, in terms of a coming mandate, could improve public health, just to draw the committee's attention to. The need for a new skin cancer strategy in Northern Ireland, the opportunity to debate and potentially legislate for the banning of commercial sunbed use, the development of a new tobacco control endgame strategy and an obesity strategy. These are just some of the things that could have a significant impact, not just on tackling cancer incidents, but other disease with associated risk factor. Secondly, and finally, addressing the emotional and psychological needs of people living with cancer is critical. And we all here today endorse the position that that needs to be seen as a priority. Practically speaking, there needs to be a greater recognition of the role of cancer-specific counselling and psychotherapy. And certainly at Cancer Focus, we have called for a regional psycho-oncology framework, which identifies best practice, clear referral pathways, and with the aim of establishing a regional psycho-oncology service. And certainly from a sectoral perspective, there are many organisations, ourselves included, that can work meaningfully in partnership, who have the infrastructure and the expertise to provide this support and complement the diagnostic and treatment pathways, thus improving patient experience and outcome. So thank you for the opportunity to make those brief opening remarks.
Thank you, Richard. Alistair?
Thank you for the opportunity to brief you this morning. At Macmillan Cancer Support, we are delighted that Northern Ireland is soon going to have a cancer strategy, and we absolutely welcome its vision and ambition. We've been involved from the start with people living with cancer and with the Department of Health and other stakeholders in developing that. And we fundamentally believe that now is the best opportunity in decades to improve and to future-proof cancer services. The strategy provides the tools to do that, a visionary approach to personalised care, a commitment to build the workforce, and alongside the cancer recovery plan, it provides direction to address the systemic issues that have led to disruption during this pandemic. There's much to celebrate there, recommendations to provide everyone with a clinical nurse specialist throughout all of their journey, alongside a holistic needs assessment and a care plan. And we know that those commitments, once delivered, will have a huge impact on people living with cancer. Taking the clinical nurse specialist example, for instance, someone I met recently told me that their CNS was their angel that guided them through their treatment and their care. All of the charities here agree that there's an urgent need to address health inequalities in cancer care, and there are some recommendations within the strategy, the draft strategy, around health inequalities and prevention. However, health inequalities do exist at all points of the cancer pathway, not just in contributing to the development of cancer, but also in impacting what type of treatment you might receive, your ability to access support, and your overall survival. And we know that the strategy is looking at some specific pathways and improving data in that regard. But we also want to see, through the implementation of the strategy, a clear plan for addressing health inequalities and identification of the key metrics in that regard. And at Macmillan, we firmly believe that personalised care is a key enabler in closing health inequalities across the cancer pathway, ensuring equitable access to emotional, practical and financial support, and taking a holistic view of supporting people with multiple intersecting needs that go beyond the clinical remit. Finally, at Macmillan, we want the next Assembly to ensure that cancer doesn't become the forgotten sea of this pandemic. We urgently need to transform cancer care and to support cancer services to rebuild from the disruption of the pandemic. As a member of our cancer experience panel who I met recently put it, it's now time to get behind this strategy and to provide sustained funding, treatment, research and support for people in all of our communities.
Thank you, Alistair. And John.
Thank you, Chair, for the opportunity to brief the committee today on the impact of patients with cancer and their need for palliative care, and in relation to our involvement in the cancer strategy as well. We very much look forward to the final version being published and absolutely welcome it. And I echo Margaret's comments absolutely that this is the pathway forward for people with cancer. I'd like to focus on some of the key areas of concern around palliative care, first of all, and then finally to talk around workforce, which we are all in agreement is a significant issue and concern for us. Like other colleagues here today, Marie Curie is incredibly concerned about the impact of the current situation on the cancer strategy and for palliative care services for patients with advanced cancer. Margaret's already highlighted the significant risk around the lack of funding. And whilst it's not our place to comment on political issues, I'd add that the failure to deliver on the promise and ambitions of the cancer strategy will have a devastating impact for people with all types of cancer, as well as those with a terminal diagnosis. Another significant risk from the current situation is that the palliative care recommendations in the cancer strategy would ideally be bolstered by a much needed and long awaited palliative care strategy, and the programme for government and on that finally the latter issue, we had lobbied for the inclusion of a key priority area on death, dying and bereavement. Those would also be in jeopardy. Neither of them can be signed off or progressed without an executive. In addition, the current Northern Ireland Bereavement Network's body of work to improve support to people with complex grief as a result of the pandemic is also at risk, as well as the design and delivery of a new bereavement strategy. These are critical policy drivers to deliver desperately needed support for patients at end of life and their loved ones. A further issue is around the identification of palliative patients. I updated the committee in April last year around the anticipated impact of COVID on palliative patients, and that included concerns around late identification. Timely identification for palliative care is so important for management of symptoms, often from cancer treatments themselves, to provide the best possible quality of life for patients in the time that they have left, and help them prepare and those close to them for what lies ahead. Because patients are being diagnosed later with cancer because of the disruption to services from the pandemic, we're also seeing late presentation at the palliative stage, meaning patients with terminal cancer are missing out on care and suffering as a result. To put it in stark figures, data as far back as 2015 from the Cancer Registry shows that nearly 30% of cancer deaths in Northern Ireland occurred within 90 days of diagnosis. Although we don't have current statistics, I'm in no doubt this already shocking statistic is far worse today because of the pandemic. And my final point is around workforce, and we were all in agreement this is a significant pressure. The health sector was already struggling to attract and retain an adequate health workforce across many disciplines prior to the pandemic. Workforce pressures have now very much come home to roost because of it. Staff absences are at an all-time high due to COVID or isolation, sickness, burnout, stress, and many are also accelerating retirement plans as a result, further exacerbating the issue. Recruitment and retention of nursing and medical staff is difficult, and these growing and increasing pressures are all against a backdrop of increasing demand from patients. We only have to turn on the TV and see what's happening in Daisy Hill and across other trusts to see the impact of this perfect storm. These workforce issues are not specific to one area or discipline. We see it right across Northern Ireland, and its impact goes across all medical disciplines, including oncology and the palliative care workforce, which is very wide-ranging. This includes specialist palliative care consultants and nurses, palliative pharmacy, primary care, GPs, district nurses, and essential domiciliary care provided through care package. It's important to say the pressure on staff can't be underestimated, and to note that staff are also impacted by cancer and loss, as well as our patients. These are only a few of the issues facing cancer patients and their families needing palliative care and the staff who provide it. And I would urge the committee to support any measures that can help secure the delivery of the cancer strategy to support them.
Thank you, Joan, and thank you to all of the panel. I have to say I share your concern across a range of those issues. We are clearly, in terms of the strategies, there are some of the strategies clearly in need of updating and reinforcement. And I would add actually the oral health strategy, which is significantly out of date to the ones that have been mentioned by yourselves earlier. Also, that workforce issue is fundamental and creating difficulties in all sorts of areas, including current delivery and planning. But in relation to, and I just want to mention again the fact that I met with a number, myself and the Deputy Chair met with a number of terminally ill women yesterday in the building here, and I have to say that was particularly difficult, given the situation they're in. But they also referenced on several occasions the lack of emotional and psychological support, even at the point of communication of the diagnosis, which was really shocking, I have to say. So I wonder, could you say, is there more could be done? I feel there probably is more could be done, but what more could be done and should be done in relation to providing people with emotional and psychological support, certainly at the point of communication of a diagnosis and support ongoing from there? So whichever of you feel you would like to pick up on that.
I'm happy to speak into that, Chair.
Go ahead, Richard. Thank you.
Any other colleagues want to contribute? But yeah, I think it's we very much see this as a holistic opportunity alongside the diagnostic and treatment pathways. Just to give you a little bit of insight into, Cancer Focus provides cancer-specific counselling in most of the health trust on hospital location throughout Northern Ireland, and COVID-19 actually I think highlighted the vulnerability of the service, because we as an organisation had to furlough professional counselling teams for a period of a number of months as a result of the pandemic. And what that flagged was the public perception that actually this was a service that was systemic. It was part of what was being offered alongside the other pathways. And obviously at that time there was a perfect storm in terms of heightened anxiety and distress for patients, where maybe there had been delayed diagnostics or treatment pathways. So I think there's an opportunity to more meaningfully partner with our sector, because we are mobilised and we are ready and we have resource and we have staff that can partner in a meaningful way. And I think that's from a workforce perspective, we appreciate the challenges that are there, but for a modest amount of funding, I think we need in Northern Ireland to provide people with the dignity of having that emotional support at what is one of the most difficult points in their life, receiving a cancer diagnosis. So I think I think there could be concrete and practical discussion with trusts about how we could expand and roll out that service further.
Yeah, and I have to say I agree with you, Richard, and we have actually heard in committee here previously the department referred to in a table they supplied us with around workforce issues, alternative workforce. And actually when I drilled into it, the alternative workforce they were talking about was the third sector to some degree, and I do believe that there is expertise and capacity out there. We've also heard from 123 GP in relation to support that they could provide. And I don't get a strong sense that those have been maximised. We're also conscious that at the workforce appeal, there are still outstanding 25,000 applications on the department desk of people who came at COVID as a response to COVID, and I'm not convinced that has been effectively trawled and effectively implemented to get some additional supports on the ground to support patients and to support those providing healthcare services, I have to say. So that is something I would be significantly concerned about. But listen, for now I'm going to move on to other members, because I'm very conscious that we have quite a full session today. So I'm going to move on to other members. So I have at this point Carol, Deborah, Colin, Paula and Pam in that order. So I'll go to Carol and Colin. Lana, aye, Carol?
Carly, and thank you very much to you all for your presentation. Even just reading the document, the 8 charities come together is very significant, and it's no accident that the issues that you've all identified are issues that have been persistent and consistent. I mean, my kind of questions would be, first of all, we raised the issue with the finance minister that up to £182 million for cancer recovery and cancer care could potentially be lost, or certainly stunted as a result of not having an executive, as a result of the DUP pulling the First Minister. So I want to ask, what discussions you've had with officials in terms of what will seem like a weekly budget? What impact will that have? Have you had those discussions? The other aspect is in terms of the furlough of counsellors. Are those face-to-face sessions being resumed, or is it still done virtually? And my last point is this: I just want to put it on record. We lost our father as a result of pancreatic cancer, and he was dead within weeks of a diagnosis. But the services and supports that we received as a family were second to none. Unfortunately, we lost our mother just before Christmas, and she received palliative care in the hospital. But talking to some other families who unfortunately had a return of a relative, they were basically saying that despite the excellent services and support our nursing staff are doing at hospitals, and they're literally run off their feet. Their retention and recruitment right across health and social care is extremely concerning, and we've seen that in recent days. So how can we ensure the level of care in terms of palliative services will be given to all families? Because it made our grieving process a lot easier, I have to say. It really did. So how can we continue those in light of the current political and indeed financial circumstances that we're in? Thank you.
So if I could ask...
Carol?
Yeah, go ahead, Joan, yeah.
Yes, sorry, Chair. Yes, Carol, if I could address your question around palliative care. It's a very wide question in terms of what can we do to secure that and secure that support for patients. And you're quite right, it is very variable right across the north, absolutely, and it depends on what trust you sit in terms of what services are available. I would also concur that getting the care, when you get the care is second to none. We have fantastic workforce, totally dedicated staff, and there's lots of evidence out there that our nursing staff work far longer hours unpaid than any of the other nations in the UK and across these islands as well. I would say that we need to absolutely look at our workforce strategy and make sure that we invest fully in the workforce. And for palliative care, it is a very diverse, multidisciplinary range of clinical support that is needed to manage care. So we need to make sure that we have the workforce strategy in place for all of that care, both in the community setting and in the acute setting. And we need to make sure that the system flows smoothly so that we can discharge people in and out of acute settings as well, because it's a very fragmented system at the moment. We know that there's excellent pockets and then people fall between the cracks as well. So investment in that and training, and to the Chair's earlier comment as well, these are some of the recommendations we've put into the strategy around training and having those additional support for training to have the difficult conversations as well. We know that supporting staff when they're particularly at burnout is so very, very important, that we need to have the supporting, staff in place to be able to fill those gaps as well. And making sure that we invest in that is absolutely critical. And it's important to note as well, I've said before that our staff currently at the moment are also patients. They're experiencing loss and grief as well, and we're seeing very high numbers of staff off bereavement leave, stress and anxiety as well. So, we need to make sure that we, look after our staff who are also impacted by this as well.
Thank you. And what was your other part of your question, Carol? If I could ask somebody to briefly pick up on that.
Yeah, it's just in relation to the budgets, the way they are at the minute. They're so precarious because of the decision of the DUP, but the Health Minister made it clear. And again, we picked it up with the Finance Minister, that 182 million for cancer care cannot be cleared in absence of an executive. So what discussions, if any, have you had with the department in relation to this? Because that's the big concern with her.
Thank you. Alistair, were you going to pick up on that?
Yeah, I'm happy to pick up on that. Obviously, a group of charities have come together previously to set out a position on fully funding the cancer recovery plan. So we have previously written to both the Finance Minister and the Health Minister on that. I would say it's absolutely clear that we need urgent investment in the cancer recovery plan and in the cancer workforce. And we need to secure that as soon as possible. There's been really severe disruption across cancer services, and we know that the workforce are pretty exhausted at this point. And in addition to that, we've got a backlog in cancer care of people yet to enter the system as well, and that'll put pressure throughout the pathway as those people progress through it. So now is really the time when we need that sustained funding to transform services, and we've seen that shorter term sticking faster approach to funding doesn't work in delivering these kind of big strategic objectives. And to give you an example of how urgent that funding is, obviously there's a cancer strategy commitment around providing everyone with a clinical nurse specialist. Macmillan's modelling shows that we need 100 more of those by 2030 to deliver that commitment. And to do that, we really need to start training now, but that requires recurrent investment. So delivering this strategy is going to require that sort of longer term approach to funding it.
Thank you. Okay, I'll need to move on then to Deborah. Go ahead, Deborah, please.
Thank you, Chair. And I just want to thank the panel as well this morning. I was just wondering, firstly, how do we address the continuing challenges regarding diagnosis of certain cancers, including lung and neurology? That would be my first question.
Yep. Could someone indicate?
I can take that one if you like.
Yeah, go ahead, Margaret. Thank you.
Thank you. There are a range of cancers that are more difficult to diagnose, certainly. Part of it can be the nature of a specific disease, that it does not show symptoms until it has progressed to a late stage. That, for example, is true of pancreatic cancer. In things like lung, one of the things that people have really been looking at is the extent of a cough. That sounds really simple, but the reality is smokers, which are the largest but not exclusive sufferers from lung cancer, smokers have a tendency to just say, oh, it's my smoker's cough, it's just the way I am, when in fact some of them need to be assessed more deeply to find whether there is something else going on and it's not just a smoker's cough. There is, for example, a pilot program in the Southern Trust looking at that particular issue. There is also the UK National Screening Committee is looking at a national screening program for lung cancer, which we hope that they will have an answer on the end of this year or the beginning of 2023. And one of the commitments or one of the asks in the cancer strategy is that the department and in the case of screening, it's the Public Health Agency, act more quickly when recommendations are made to make improvements in screening systems. We are behind in pretty much every screening system except breast cancer. So, for example, when that gets announced, we hope, as a national screening program, we need to get behind that and get behind it quickly. We have a very high rate of lung cancer. And it's important that we get people diagnosed early, because you can treat it. It's very difficult to treat if you leave it too long and are diagnosed at late stage. But there are things that we can do to diagnose people earlier. I hope that answers your question.
Yeah, thank you. I think it's a case of, isn't it, investing sort of to save it. I don't like to use that term, but, in terms of getting early detection, that can save lives and obviously, help the health service as well in terms of its delivery model. The next question I just wanted to ask was around, had yourselves engaged with the Minister beforehand on the budget and what money that you would need for a fully funded cancer strategy? And do you think that, maybe having looked at the budget, as presented, would that deliver on a fully funded cancer strategy? And then my last question is, what would you say is the current picture regarding elective surgery for cancer, and to what extent does it differ from red flag and separate cases?
I can continue to answer if that's all right with everybody else. The question about surgery. Surgery for cancer falls into surgery. It's not separated out, if you like. Surgery, as everybody knows, I think, was greatly impacted by COVID in terms of workforce, especially very experienced theater nurses being taken away from surgical duty to serve in COVID wards and ICUs, et cetera. That has largely stopped, and the staff is back in surgery. The issue, though, is the backlog is so significant in surgery that it under current ways of working, it will not be able to recover quickly. Surgery is not something you can speed up. A surgery takes as long as it takes, and you can't change that really. The other issue is lots of people have not attended hospital or their GP for various issues that they might have, and consequently people are presenting later and potentially needing surgery where they wouldn't have at the beginning if they had presented earlier. So that makes the emergency surgery more of an issue. And obviously, the way that our surgical system is organized in Northern Ireland, for the most part, surgery is done on sites with acute accident and emergency departments. So emergency surgery always takes precedence, and hence cancellations for elective surgery or planned surgery, and which would include cancer. The Royal College of Surgeons in Northern Ireland has done quite a lot of work and made various presentations to the Minister about ways that the surgical system, whole surgical system, could be improved in Northern Ireland. And my understanding is that he is looking very seriously at those and has already made some changes to try and enable those. So doing more surgery in smaller hospitals, for example, without accident and emergency where that's possible. So there's no chance of cancellation, and you can catch up much quicker if you do that. So surgery is not necessarily our expertise, but the Royal College of Surgeons has an excellent program, as I said, which I know the Minister is looking at and has implemented bits of. And now I've talked so long, I've forgotten your first question.
No problem. It's very interesting to hear, Margaret. That just my last question was, in terms of yourselves as charities, what engagement has you had with ministers beforehand on the budget that you would need for a fully funded cancer strategy? And do you think that the budget as presented would deliver for that fully funded cancer strategy?
Right. The budget that was in, or the budget for the Cancer Recovery Plan or the Cancer Strategy, the Cancer Recovery Plan is technically the first 3 years of the Cancer Strategy. It was presented in early last year, before the Cancer Strategy was final. So it was presented with a funding need of £108 million, I believe. I think all the charities input to that to some degree, although funding, calculations in terms of need, the department does those, so that we wouldn't have much input into the actual calculation of the budget need.
Thank you, Margaret. I'll need to move on. Thank you.
Okay.
Colin, go ahead, please.
Thank you very much, Chair, and thank you to the panel for their presentation. There's a theme running through my own head, which is that it's a real embarrassment and indictment on the political world that we're here discussing about trying to get a cancer strategy in place. I would doubt that there's any one of the 90 MLAs currently, or the 90 MLAs that will be returned after the election, that won't have been touched by cancer in some shape or form, either personally or by their family. and why an issue like this isn't front, centre and priority is always a worry. So I hope that we can, for our part, do everything that we can to try and ensure that this strategy is delivered and is a reality as quickly as possible. And I was just wondering, maybe on that vein, to give us some sort of indication and highlight from that. Can you tell me, maybe just from your own experiences, what the impact has been of not having a strategy?
Yeah, I'm happy to jump in there, Chair, if that's okay.
Yep. Go ahead, Richard. Certainly. Thank you.
Yeah, thanks, Colin. I think I totally agree with your sentiment. I think everyone here would agree that people in Northern Ireland deserve a cancer strategy. I think we're the only region that hasn't had one. On these islands, and I think that's important for a number of reasons in terms of just having ambition and vision, but also, I suppose, coordination and cohesion, because on a cross-departmental basis as well, because a lot of these themes are cross-cutting, and I think it's essential that we don't just have a published strategy, but that we do have a funded strategy, and that's quite clear, and there's a unified voice certainly from our sector on that. But I think people deserve coordination and cohesion around how we prevent the incidence of cancer, and also then having access to the services to be able to deal with and live with that experience. So I think there has been a cost to people in Northern Ireland, because we haven't had that intention in the past, and I would just encourage all of the, obviously we're not political at all, but what we feel we need sectorally is a programme for government that will reflect the ability to actually roll this out in a meaningful way, and that's not nice to have, it's a must to have on behalf of the people that we serve.
Could I add a point, Chair, if we have time, very quickly?
Yep, go ahead.
It's to say, I think there is an assumption that our citizens assume that the services will be there for them, and they have assumed that. And it's you don't know what you don't know until you're in that situation. And since the pandemic, all of this has come home to roost. People are seeing a system, on its knees already, and the pressure between the demand that's obviously increasing, late diagnosis, late presentation, a stretched workforce and uncertainty over the budget it's just a massive perfect storm coming together, and people are now realising that those services that they should have aren't there. So, it's why we need the strategy to highlight and address all of the barriers, all of the issues, all of the cracks between all of the different parts of the system, that we seamlessly address them. And I think that's the fundamental point for me, that people know that it's there and that we're working to address and provide a cohesive service for them.
And I suppose, Chair, just to add that a strategy, obviously by its very nature, provides the strategic direction for services, but it allows you to sort of horizon look. And I think it was yourself, Richard, that had mentioned that in the next number of years the number of cases is going to double, and that prevention is going to very firmly need to be a strand of any strategy that we would deliver. Can you give me a flavour maybe just of some of those headline preventative strategies that could be maybe pursued very quickly if the strategy was developed, and then just what sort of outcome we might see from those?
Obviously the Northern Ireland Cancer Registry produce really good information and data that's intelligible and looks forward in terms of trends. And just to give you, I suppose, a practical example, there's a huge increase in incidence around, melanoma skin cancers, as an example. And when you look at the level of investment, perhaps that is put into prevention via the PHA in terms of Be UV aware and skin cancer campaigns, I think there's a health economical argument, very clearly around how we can reduce the incidence of a cancer that's entirely preventable. There's international precedents, and there's an evidence base to suggest that If we invest in that area, we can reduce the cost and burden in terms of the particular treatment for that particular cancer. And that's just one practical example of, of how we can strategically speak into trying to deal with what's coming down the tracks.
Could I, if we have time, Chair, could I add a further comment? Sorry.
Briefly, John,
And whilst we don't have prevention in palliative care, I would add that prevention is obviously priority, but people will still come to an end-of-life journey. And it's really, really important that we also address the public health approach to palliative and end-of-life care. So that means the whole increasing awareness of the benefits of palliative care and addressing the taboos around talking about death and dying. And that also helps increase and help those conversations, those difficult conversations that clinicians need to have with people who unfortunately have a terminal diagnosis. Thank you.
Thank you, Joan, and thank you, Colin.
Thank you, Chair.
Paula, go ahead, please.
Thank you, Chair, and thank you, panel, for the update today. Great to see you all at Health Committee. I'm just wondering about clinical trials and how much you think the strategy will enable those going forward. I know that's a key issue in terms of access to emerging drugs. That's the first thing. The second thing is in relation to the role of the community pathology sector in terms of hospices, and whether there are discussions with the Minister around full cost recovery for delivering those services instead of the charities having to fundraise themselves. And then the last one was really just about the other strategies, and I think Colin picked up on that in some ways, but I'm just wondering if we had, how are we going to prioritise the work going forward when there's just so much is needed around preventing and treating cancer? Thank you.
Paula, do you want me to take the question around the funding on the hospices?
Please.
Very quickly, I know that there are discussions around increased fundings for sure, certainly in the hospice sector, and I'm pleased that you've mentioned it because it's one of the critical services that is so reliant on the third sector, palliative care, and as you mentioned, it's absolutely shocking that we need to rely on public donations and cake sales and marathons to provide such a critical and essential service. So yes, those discussions are happening, have happened. Although I would add, we need to follow up on those conversations because there is a lot of uncertainty because of the current situation. So we don't know where we currently stand with that. But absolutely, if that can be secured, anything towards full cost recovery is very much welcomed. And it means then that we can also focus on the wider issues that a lot of the hospices provide as well. One of the particular areas is around bereavement, which is nearly fully provided by the third sector as well. So that is one that absolutely needs to be addressed for sure.
Briefly, Alistair, please.
Yeah, if I could just quickly pick up on that third point in terms of actually implementing the strategy. Obviously, we know that workforce and funding are key enablers. There are other enablers that we need as well. So we need to improve the data that we're collecting to ensure that we're monitoring progress against delivery of the strategy, but also ensure that we're reporting then against that progress. But we also need really robust governance arrangements for actually delivering this document, and that has to include regular review points and, as Colin mentioned, the opportunity to horizon scan, because obviously this is a 10-year strategy, and as we've learned over the past couple of years, things can change quite quickly, and we're going to need to ensure that the governance arrangements allow that kind of flexibility and adaptation of approach as well. And I would say, alongside that, there's a key point is going to be integration with other and alignment with other strategies that have been developed. We've seen the mental health strategy, for instance, has come out as well. And a person I spoke to recently told me that her experience was that she fell between two stools in terms of mental health support. She was getting some support with her mental health and some with cancer, but they weren't as aligned as they could do. So there's a real point there about looking at how this cancer strategy aligns closely with others that the Department have published.
I think it's just about the clinical trials, Chair.
I can take that one if you like, Paula. It's my understanding that the final version of the strategy will have an improved section on research in general and clinical trials in particular compared to the draft strategy, which we've all seen. One of the things that is important is about staffing, and it's contained in the whole workforce piece. They were very much interrupted during COVID when, because they're very experienced nurses in the research field, were taken away to do other things, now returned to research, hopefully, and catching up. The issues over access to medicines in Northern Ireland did affect the clinical trials, as there was some nervousness about from sponsors about participating in trials here, but that seems to have stopped. The other issue in addition to workforce is about regulation and making sure that it is as easy as possible to set up proper clinical trials in Northern Ireland so that we can benefit from all of the ones that we could benefit from and that patients can benefit from those as well.
Thank you, panel.
Thank you, Paula. And Pam, go ahead, please.
Thank you, Chair. I wanted to ask a question to Margaret, following on from Deborah's question. So, do you believe that the draft budget as presented delivers on the 108 million that you talked about, that you need for fully funding the cancer strategy and recovery?
The draft budget specified, I think, 184 million for cancer. That included 108 for the cancer recovery plan and the balance of 70, whatever it is, for other things that have been requested over a number of years for cancer that have never been able to be funded in the past. The comment that I think I made or meant to make is that the cancer recovery plan, because it was published before the final draft of the strategy, did not include budgeting for workforce. So any workforce amount is not included in the 108 is my understanding of it. So it certainly goes a long way, but it doesn't do the whole first 3 years of the cancer strategy is my understanding. I know that the department is working on full budget proposals to be published with the strategy. And I don't want to preempt anything that they say, and I'm not privy to all that exact information, but it's my understanding that it would be greater than that.
Okay, thank you for that, Margaret. And I suppose my next question was going to be in and around, to what extent the action set out in the cancer strategy are dependent on addressing the short and long-term workforce concerns. So if you had any further comment on that. And I wanted to ask you as well whether you believe there's a need to streamline the waiting times across trusts and communities, and how we balance that need for a more regionalised approach to cutting waiting lists, whilst also retaining effective and convenience in terms of access to services.
I'll take the last one first. The waiting times, as you know, we've never met 62-day waiting time in Northern Ireland, and it's only continued to get worse during COVID, as would be expected, to be honest. Waiting times in certain things are trying to make them a Northern Ireland-wide waiting list rather than by trust. But that's very difficult because of communication systems and computer systems and staff. But they are trying to move people around where they have differences. For example, the Northern Trust has had several problems with their breast service. So patients from the Northern Trust have gone for diagnosis and to the One Stop Breast Clinic to Belfast. And some to the Western Trust, I believe. So they do work across trusts on an individual sort of basis, but there is certainly more to be done on that, and I think the department recognizes that. In terms of the budget and dependence on workforce, there is no question that workforce is probably the most overriding issue for cancer services. It varies by trust, it varies by specialty, it varies by tumor type, but it overall is a huge issue. And unless we can find a way not just to have more people, but to make the way people work better. So we call it skill mix, so that everybody works at the top of their license, so that you free up time for the person above you to do what they're supposed to, what only they can do. And some places and some specialties are not as good at that as they could be. And there are changes to simple things that adding more administrative staff and technical staff can improve the way things work. It is not all we need more doctors. We definitely need more nursing staff, but there are ways to make the workforce more successful and better prepared, rather than just saying we need more, more, more. We do need more, but all those other things too.
Okay.
Could I add a very short point to Margaret's comment, please, Chair?
Go ahead, John.
I just want to add that certainly for palliative care, it's a systemic issue. You know, it's across the acute and the community sector. And it was just to add that we are seeing and have seen excess deaths in the home setting increase dramatically by over 1,700. Comparing 2021 to previous average years. So it's important that we get the whole disciplinary workforce all aligned, so that if you don't just improve it in one area, so especially in the community as well, we see an increased need for, you know, very important areas like social care, and we know that significant churn issues in that sector as well. So it's a matter of making sure that we address all of the workforce pressures in all of those areas as well.
Okay, thank you. Orlia, go ahead, please.
Thanks very much, Chair, and thank you to everyone on today's panel. So maybe just to come back to the conversation there with the issues that Pam and Deborah had raised with Margaret around the draft 3-year budget and what would have been included within that in terms of the cancer strategy. Margaret, you did say in your opening comments that you were calling for a commitment to that 3-year draft budget to try and obviously progress the work around the cancer strategy. So I would just, my first question to the charities would be, is that your position where you are calling on that commitment from all of the political parties to deliver on this 3-year budget in terms of hopefully what transformation that could or should make in terms of cancer? And my second question is around, I think that it is pretty clear that if there is failure to implement the 3-year draft budget, even in terms of, you know, that failure will be as a result of, you know, not getting agreement on the draft budget. That needs to be agreed at executive level. We don't have an executive at present. So I'm hoping that things can turn around and change over the coming weeks and months, and that we are able to deliver on this. But I think it was in Joan's comments as well. Joan, you had talked about what would be a devastating impact if this isn't delivered on. And I know that the different speakers have already touched on different parts, but really in terms of, like, for the public that's watching in the committee meeting today, when we're talking about a devastating impact, we can see that things are already in a dire situation in terms of cancer, particularly with the pandemic. So what is this devastating impact that we could be facing into if we don't have an executive and if we don't have that multi-year budget for this cancer strategy? Thank you.
Thank you. Yeah. Alistair, were you going to come in there?
Yeah, I'm happy to pick that up. In terms of, what I would say is delivering the recovery plan in the first 3 years of the strategy is urgent. And, you know, that's going to require a real political focus and the funding to do that, because we need to tackle the backlog. We're going to need additional capacity where there are pressures on the system. And we need to ensure that we transform services and build them back from the devastating impact of the pandemic. And obviously there are costs out there in terms of the cancer recovery plan, and that's critical investment now. But alongside that, we need to take that approach to building the workforce. And I would say the pressures on cancer services aren't going away anytime soon. We can see we've got that backlog of people yet to enter the system and the backlog of care. But we also have a more complex cancer population in the future and a growing cancer population that we're going to have to address also. So regardless of what investment goes in, that is going to be the case, and services will have to address both the long-term impacts of the pandemic, but also a growing and more complex cancer population. So what I would say is that investment is really urgent, and if anything, what the pandemic led bare is that services were facing some real systemic challenges, and that there was some fragility there, and we need to address that now as we come out of the pandemic.
I would add as well that if we don't progress the cancer recovery plan, we'll actually be going backwards. We know that we need the next 3 years to implement the immediate, absolutely critical, pressing needs that are glaringly obvious that we're seeing every day. They're just worsening every day. But we also need that funding to be the first building blocks for transformation. We have not been able to transform for so many years because of an annual budget. Now, we have never seen the pressures that we are now between the increasing demand from patients and presenting with such complex and critical needs. So the pressure is really acute, but we have a workforce that is struggling to meet that demand, and they are burning out. So we need to transform, we need to put the building blocks in, and this 3-year recovery plan is the start of the building blocks. We're failing our population if we don't put it in place.
Yeah, I would just concur as well. I think, a consequence of not being able to look ahead over a 3-year period, potentially from a budgetary perspective, is that we lose the ability to actually innovate and transform. And I think the one thing actually that COVID has demonstrated, and we listened to colleagues, maybe the Royal College of Surgeons, and maybe some of the work that has been innovative around trying to regionalise service and look where resources available across trusts, etc., in terms of surgery, when there's been acute issues as a result of COVID, that actually people have been able to pivot and innovate and do things differently. And just to build on, I think, what Margaret said earlier, that's critical. But if we're in a scenario where we're just on a standstill or potentially go back budget for another year that rolls on, then we lose that opportunity.
Okay, thank you, Arlia. Alan, go ahead, please.
Thank you, Chairman. Chairman, I'm disappointed that some politicians are still trying to score points when they would be better reflecting on the recent actions of their party. I think the public are seeing through the attempts at political distraction that are going on at the moment. The success and the progress of any recovery strategy, but most importantly, a cancer strategy, is built on the premise of a multi-year budget being available to whoever is the health minister going forward. And the only people that are damaged by the current collapse of the executive are the people of Northern Ireland. The charities that are here, they are the voice of the people that are suffering and that are going to suffer. And we have to listen very carefully to the message that they're giving us this morning. I'm embarrassed that they're having been asked to have to deal with this political impasse. Jean says that with the multi-year budget, we're going backwards. Are we as politicians happy to be part of that? Is that our legacy, that we're going to go backwards instead of forwards in terms of cancer strategies and all the other strategies that are going to be damaged by this impasse? Thank you, Mr. Chairman.
Thank you. Yep. Does anyone want to pick up on that? There wasn't a clear question, but does anybody want to comment on that? No. Okay, Alan, that was a comment, I take it, more than a question. Okay, I don't have Alan there. Okay, listen, so I have to say there would be huge concerns in relation to even the recent figures around the workforce vacancies. We had already been sitting on a situation where there's 6,500 workforce vacancies out there in the system, and that's the equivalent virtually of a Royal Hospital, an entire Royal Hospital missing out of the system. Those figures have actually got worse and they've increased by over 600 in the 3 months between September 21 and December 21, including all types of specialists and general nurses. So it really is a situation. And the other thing is that clearly one thing where you require longer term funding is employment, where you're employing people. You have to have the certainty of being able to offer them longer term contracts. And indeed, in doing building upon pilot programs with organisations like yourselves, it's a struggle doing that year on year. We're in a situation at the minute actually where we don't even have year on year. Actually, in effect, it will be on a 3-monthly basis if this situation is not resolved. So I think that's of massive concern. But listen, I want to thank you all, and I want to thank you all for the brevity with which you dealt with the issues. I know you're all very expertise in your particular fields, and you have communicated a lot of the information to us previously and indeed again today, and that concern that you're feeling as well. So I want to thank the panel for attending this morning, and we will move on into our second session on this, which is with the department officials, and we will no doubt pick up on some of the issues that's raised. But for now, Margaret, Richard, Alistair and Joan, I want to thank you for attending committee and providing us with your input. Gormila Mayagav, and take care. Thank you.
Thank you.
Okay, members, so I'm going to move on then directly to the Cancer Services briefing from the Department of Health. And we can do a discussion after that, but we'll take the briefing. This is the second of our briefings on cancer. I refer members to the Department's paper at tab 6.1 of the pack, and to copies of the Cancer Recovery Plan and Cancer Strategy Consultation at tab 6.2 and 6.3. So I would now like to welcome to our committee meeting Thomas Adele, Director of Hospital Service Reform in the Department of Health, newly appointed to that role indeed, where we've seen Tomas on several occasions in other roles. Good morning, Tomas. Can you hear us okay?
Good morning. I can hear you well, Liam.
Thank you. Yeah, we're hearing you. We're also joined by Gay Ireland, who is Head of Cancer Service in the Department of Health. Can you hear us okay, Gay?
Yes, I can hear you.
Thank you. And Paul Kavanagh, Interim Director of Planning and Commissioning, Health and Social Care Board. Can you hear us okay, Paul?
Yes, thank you, Colin.
Thank you all. So listen, very welcome this morning. We'll move straight to the briefing, and if I could ask to be as concise as possible with the briefing and indeed with questions and answers. If one person on the panel can lead on a particular answer, and only if necessary then an additional information from someone else, and we'll try to move through in that fashion. So I'll go back to yourself, Tomas, and see, would you go ahead and lead off on the briefing, please?
Yes, thank you very much, Chair. I believe you have got my speaking notes sent to you, and I know that we are running quite late, so I'm not going to go through the whole speaking note, but I want to say a quick summary of a few key things. First of all, I want to say that it's good to be here to speak to, and cancer is something that we all really care about. We all know someone who has cancer or has had cancer. And I mean, it affected all of us. It affected myself as well, with one of my best friends being diagnosed with cancer when we were both in our 30s, and my mum dying of cancer about 12 years ago, albeit in a different country than here. Also, I really want to provide the committee with a full commitment that we're fully committed to improve cancer services in Northern Ireland and to improve outcomes for our whole population. That means we'll have to work together going forward and jointly make difficult decisions. We heard about some of the difficulties that face our cancer services this morning from our charities, and we can only echo many of those difficulties. Across our services, we have a huge dedicated workforce that includes doctors, nurses, allied health professionals, others, community volunteer sector, and a large group of people. However, even with this dedicated workforce, cancer survival is behind other members of the International Cancer Benchmarking Project, and that is something that we definitely want to change and improve. As we all know that our waiting lists are not quite where we want them to be. We're missing our targets, and despite additional support, none of the targets have been met in the latest published data. This is particularly concerning for the 14-day breast cancer assessment target, which is poor and has gone worse over Christmas and January. And this is clearly not acceptable. We also know the difficulties across red flag services that especially refers to many things. I can please say that many of these things have picked up lately. In terms of screening, breast bowel and cervical screening programs were all severely affected by COVID-19. All programs were paused in March 2020 and did restart on later that year. However, all screening programs are now operating and operating at a higher capacity than before the pandemic. For example, in the 3 months, July to September 2019, about 19,500 women were invited to breast screening. The same period in 2021, so almost 22,000 women, meaning a 13% increase in the number of people screened. In terms of bowel screening, there's also been a significant increase. In 2019-20, about 22,400 people were screened. In 2022, this is up to about 27,800, which is 24% increase. And it's really good things to celebrate in these really difficult times. There's also been, we know that there are significant challenges with endoscopy, and we know that there are a large number of people waiting for red flag endoscopy appointments. Work is ongoing by the Regional Endoscopy Modernisation Reform Group to optimize capacity. This includes using all available methods we have, such as the independent sector, regional services, and both Northern and Western Trust are creating additional endoscopy sessions, which will increase capacity. Going forward, we need to increase this workforce, and in particular on nurse endoscopists, where we have real difficulties filling posts, therefore difficulties increasing numbers. We know that oncology and hematology services have been significantly challenged prior to the pandemic, and it's got worse during the pandemic. Long-term underinvestment has increased an increase in activity levels. Demand means that the clinics are routinely overbooked, and the wait for first outpatients along and review appointments backlogs are increasing. The trusts are collaborating on recruitment on targeting posts to make sure we can address where their greatest needs are. The current position of services are clearly unacceptable, but we are really trying really hard to make improvements. To mitigate the problem, some of the problems, 90 million were provided in this financial year to help with waiting list backlog in general. This funding has been used to secure additional health social care capacity and use the independent sector as effectively and efficiently as possible. The work is being targeted initially at those patients with the highest clinical priority, which includes cancer patients. The Department of Trust are also working to address the backlog caused by the pandemic across a number of targeted work. Going forward, we clearly need more drastic actions and improvements on how services are structured. The long-term answer to this is the new cancer strategy. As you were, the draft strategy was subject to public consultation last year. 107 responses were received, with 82 responses analysed as positive. That means that we clearly are on the right track, and hopefully we'll have the cancer strategy published in the next few weeks. The strategy will provide a driver for transformation and change, and will cover all aspects of cancer care and treatment across 4 themes. This includes preventing cancer, with a focus on increasing awareness of cancer-related risk factors, supporting public health, and improve access to diagnosis. Diagnosing and treating cancer with a focus on effective and efficient screening and diagnosis, implementation of guidance, enhanced specialist services, including, for example, rehabilitation and metastatic spinal cord compression services, improved pathways, and new ways of working. The third theme is supporting people to live and die well, which is focused on supporting people through new technology and new ways of working, providing holistic support and support with well-being, palliative end-of-life care, and support for relatives. And the fourth theme is implementing a strategy, which provides for cancer workforce strategy, measuring the experience of cancer services, data, and technology. All of these actions will improve patient care and cancer services over the coming years, creating cancer services the public deserves. However, it is important to acknowledge the constrained financial environment we currently operate. To implement the strategy would require significant additional funding and will require prioritization, workforce mapping, and planning to ensure realistic delivery. The investment required to deliver the strategy is huge, and it is in addition to existing expenditure in cancer services. So with that, thank you very much for the opportunity to provide an update. I'm very happy to take any questions you have.
Okay, thank you, Tomas. I suppose, first of all, we have heard of the significant pressures in relation to the cancer charities that we just spoke to, significant and indeed growing pressures and concerns. What's your assessment of the impact of not being able to achieve that 3-year budgeting process, which has been cited for so long as a barrier to delivering transformation and reform? So what's your assessment of the impact that would have of not being able to get to the 3-year budgeting position?
Well, I mean, Chair, as we talked about before in other topics, well, without long-term planning, it is really hard to invest and plan services. While there are mechanisms to maintain existing services, the lack of agreement on a budget, including funding for the strategies earmarked in the draft budget, which included cancer strategy, it's difficult to press ahead with any investments over and beyond what we already are doing. That means it's hard to invest in new things. It'll be hard to start new things. It'll be hard to change what we're doing where new investment is required. I can assure you we'll do our very best to work with what we have and make improvements where we can, but it'll be really difficult to start new things.
Okay, thank you. Also, in relation specifically to the biggest issue of all that's probably facing all services at the moment around workforce, and we are seeing additional vacancies coming into the system, including across specialist and general nursing. How important is that 3-year budgeting and ability to plan longer term? How important is that to the workforce recruitment issues? And what are you doing urgently to address that?
Well, I mean, of course, for any workforce issue, we need a long-term planning that goes for the next 3 years, but it goes beyond that as well. We even if you had a large amount of money right now, we couldn't employ more oncologists. They just don't exist, and it takes many years to train those. So we need to start a training on those now, and we need to show the workforce that there is a future in these areas. And we can only do that with confirmation of future funding, because otherwise we can't create a post for people. We can't create a hope that there is something to look forward to. So that is a very important for our workforce and for our planning in general. We will always do our very best we can with the means we have, but as I said, we are constrained with what we can do. We can't go beyond above our existing service levels, and we can't start new initiatives without confirmation of funding.
Okay, thank you. And final one from me, Thomas. Myself and the Deputy Chair met with a number of women with a terminal diagnosis of secondary breast cancer on Tuesday, and they all highlighted the lack of support and specialist help that was there for them following that diagnosis. That was common to each of them. How will the cancer strategy ensure that there are the necessary supports for people with a terminal diagnosis?
I mean, this is absolutely vital. I mean, my mum died of secondary breast cancer, so I know the difficulties this is, and I know that this is something that we need to provide adequate support. Means support needs provided across different areas. We need to have specialist cancer support. We need to have access to specialist cancer nurses that can provide support. But we also need to have think holistically. We need to work with the mental health strategy. We need to work with other strategies and other services to make sure that we have one response, that people don't fall between chairs when people are finding life difficult or struggling, that are a cohesive approach to how we deal with people. I mean, quite often it's the system often treats people as figures, not as individuals, and that is something we want to move away from. We want to think about people first. We want to have a person-centered service, and that means improving those experiences for that you heard about yesterday.
Yeah, Paul, go ahead briefly, Paul, please.
And Colin, maybe to add, I mean, I think obviously the experience of the people you spoke to yesterday is very disappointing, because there's a lot of work has been done in relation to palliative care and in relation to supporting people, following diagnoses and indeed supporting them through palliative and end of life care. So a great deal is in place, but we know we need to do more, and the strategy offers us an opportunity to do more, Colin. So I would hope that we need to build on what we're currently doing, learn from the experience as well of patients today, but also look to the strategy as well to let us develop the services going forward. But I assure you, there's a great deal of support currently in existence, and we also work very closely and collaboratively with our colleagues within the community and voluntary sector, some of whom you've talked to earlier.
Yeah, and I acknowledge that there is indeed, I'm sure, a lot of, and that there is a lot of support out there and good work. However, it clearly is the case that it's not reaching everyone. So I acknowledge. Sure. I do also acknowledge and welcome your commitment to engage with the sector, and I think that could be done urgently and repeatedly. And we've also heard from 123 GP and other areas that there are potentially resources in terms of counsellors and counselling resources out there, and I would encourage the department to reach out urgently to that sector to see what can be done in the short, medium and longer term. So thank you for that. I will move on then to other members. So I have on the screen Colin, Carol, Deborah, Pam and Paula. So go ahead, Colin, please.
Thank you very much indeed, Chair, and thank you to the folks from the department for the presentation. I suppose maybe the first question that I would be interested in asking is just in terms, I know it's the delivery of the strategy, but maybe what has been the impact of COVID? And I know there was reference to waiting lists, but have cancer services been more or less delivered the target, or has there been a significant delay? And then if we move to a strategy, is there a certain amount of the time in the initial stages that would be spent playing catch up?
So probably a question for me, Colin, if that's okay.
Yep.
Yeah. So, I mean, it has been very challenging. The last 2 years have been very challenging for all of our services, as we all know. I actually meet fortnightly with cancer managers and lead cancer clinicians and what we call the cancer recovery cell. So I'm very well aware of the pressures that we've had. The first kind of lockdown period, that early part of 2020, really we lost a lot at that stage, Colin. I mean, it set us back considerably, and we've been trying to recover ever since, in the knowledge that obviously more people come forward requiring care and treatment. But a lot of what we've I suppose been doing is firstly seeing, where are we with our various parts of our service. So our diagnostic services have largely stayed on their feet, but not without a lot of really heroic effort, as you can imagine. Our chemotherapy services have also managed to really keep going through the period, but again, been very stretched. We've had a lot of vacancies in that space, both doctors and nurses, but we've managed to keep chemotherapy going. And chemotherapy, in many ways, has been with radiotherapy, has been how we've, I suppose, mitigated some of the challenges we've had in relation to surgery. So we've put people on different pathways than we might otherwise sort of expect them to be on, having earlier access to chemotherapy and to radiotherapy, and then the surgery. I suppose at times we have not been able to deliver that in a timely way, as we're all well aware. So radiotherapy as well has managed to keep on its feet through the period too. But it's surgery where the problem has been particularly evident, Colin. I mean, I think it's sort of people are well aware in relation to this, but a huge amount of effort, particularly in the last year. So the first year I think set us back considerably, and we've been recovering ever since. But in the last year we have, we're spending at the moment some £90 million in year additional monies on surgery and on outpatients that relates to surgery and so on. There's hardly a bit of available capacity either within our trusts or within the independent sector that we're not currently sort of using to try and catch up with ourselves. We have had to prioritise surgery, so those urgent surgeries are our highest priority. So they are being prioritised, but we're still behind on those, and we're trying to catch up consistently. We're probably able to do about 400 surgeries per month, per week at the moment. But we need to reach about 1,200 of those very urgent cancer surgeries at this stage. So as you can see, we're always behind. We have not yet caught up. COVID still continues to have an impact on us. We've created what we call green pathways, basically sort of non-COVID pathways, keeping COVID as much out of our surgical pathways as we possibly can. But that's incredibly challenging. Omicron has been incredibly infectious, and while thank goodness it's not leading to the same sort of levels of mortality and so on that we've seen with previous strains of the virus, it has still meant that we are challenged to get ourselves anywhere near to what we had previously been doing in terms of the surgeries that we would have been doing back in 2019. I mean, it is. I think we are doing all that we possibly can, but we're nowhere near back to where we want to be. And even where we were in 2019 was not where we needed to be. We've a lot more to do. As Colin mentioned earlier, there's a large number of vacancies within our health and social care system. We need to look at how we can fill those vacancies, and we need to think then about how we can develop our services through the strategy and through the recovery plan that we have. It is immensely challenging, but our staff have been heroic through it all, Colin. I mean, I think that's what people are well aware of that.
Could I ask Paul, just given that the strategy predated COVID and then it's going to be published after, I suppose we're through the worst of COVID, will there be references to COVID within the strategy and the fact that it's actually going to cause some sort of catch up that needs to be done?
The recovery plan, which was written in the midst of the pandemic, Colin, and that in many ways is the key 3 initial years of the strategy. In any case, COVID is very much sort of in our minds now, and I think it would be impossible to think about a cancer strategy that does not recognise the current position in relation to where our services are.
Okay, that's grand, Chair. Thank you very much indeed. Thank you, Paul.
Thank you, Colin. And Carol.
Thank you, Chair, and thank you, panel, this morning. I suppose my question to yourselves is the same that I had to the cancer charities in relation to the current situation that we don't have an executive, and Margaret pointed out it was 184 million is at risk. You know, first of all, what is happening now in relation to ensuring that cancer funding for cancer continues, albeit on a 12 weekly basis? The other question is, Chair Paul, you'll know this even from your own transformation over, but the staff vacancies are getting exponentially worse. So what can we do to ensure that retention is given as much focus as recruitment? And finally, I suppose, in relation to hospices, I think it was Joan had raised that our hospice movement is by and large funded through third sector cake sales, marathons, and then some. What plans are there as part of the cancer strategy to ensure that hospice services are given funding from the department on a sustained annual basis? Thank you.
Thank you, Carol. The first issue on the budget, as I said, it's very hard for us to plan over and above existing budget without confirmation of the future year budget. We will, of course, try to make this as efficient as possible. We'll, of course, try to make as good change we can within our existing budget to make sure we get the best outcomes we have. But it is incredibly difficult for us to plan ahead without an existing budget. We can't recruit on recurrent basis if we don't have a recurrent budget. That's unfortunately the constraints we're working with. In the work on the strategy, we're making sure that we are putting everything in place that as soon as we have a recurrent budget, as soon as we have confirmation of something, start things. So we're not starting at that point, but we're starting planning before we are at that point. So we're doing everything we can to be as proactive as we can in the current situation. When it comes to staff and the workforce, we know the workforce is challenging. Workforce is a huge part of the draft strategy. We will do our very best to create new workforce, but it also means retention of workforce, as you rightly say. A big part of that is showing that there is future, there's hope, that there is a light at the end of the tunnel. And we will do that by showing staff that we will improve services. We will think about how we work, how we can get the best use of the staff. And as the charity said earlier on, by getting people to do what they can do in supporting people, by removing tasks that maybe they don't have to do, we can get the best out of people, and that is something that the workforce want, and that is something that staff will be happy to do, and therefore find our work more enjoyable. And that is one of the ways we're trying to remove pressures and help people retain in the services. In terms of hospices, I know about funding of hospices from my previous role, and that kind of work is taken forward separately. We do not want to preempt or interfere in that role in the cancer services cancer strategy. That doesn't mean it's not important, and that work is ongoing separately in the department.
Thank you, Tomas. And I see Paul briefly, if additional.
Maybe just on the hospice issue briefly, Colm. We have been year on year increasing funding to hospices across Northern Ireland. We collaborate very closely with them. We appreciate that they've been under considerable pressure during the pandemic, and there has been some additional funds that the Minister has released to support them during the pandemic period, particularly due to the loss of fundraising. We will continue to do that. Hospices are our partners, and we need to work as much as we possibly can, even in the constrained budget that we face. Carol, I assure you of that. And just briefly on the issue of retention. Retention is key for us. I mean, recruitment, we really need to fill our vacancies. We really need additional staff, but we need to retain the people that we have as well, because they are highly experienced clinicians, nurses, and AHPs, and so on. But I think we also have to recognise that we're losing staff because of their experiences during the pandemic. And I think it is very challenging for staff. And I think we're going to have to also think about how we support staff and how we value staff going forward. because their experience in the past 2 years has been unprecedented for many staff. People in a career in nursing and medicine and allied health professions have never experienced what the last 2 years our staff have experienced, and we have a job to do to hold on to them and to support them to get back to what we hope will be normal as soon as possible.
Chair, can I just add something around workforce? It was recognised very early on that the cancer strategy, the workforce was a critical element in it. And back last year, the Minister approved that we started preliminary work around a multidisciplinary workforce plan for cancer. And we started this about 9 months ago with around 8 work streams covering all aspects of the career pathways. So this is moving forward to see where are we now with regards to our workforce, where are the vacancies, how many do we need moving forward, where do they, what career pathways can we put them on and career development to encourage them to come on board and to stay. And there will be a training plan aligned with that to make sure that when we need the staff, we at least are started training, bearing in mind could be 6 years for a consultant. So that, that workforce plan, we are currently still working on it.
Okay, thank you. And going then to Deborah. Go ahead, Deborah.
Thank you, and I want to thank the panel for the information this morning. I've heard an awful lot of politically sort of charged statements today, but I suppose let's deal with the elephant in the room. There was 3 years without a government, of which Sinn Féin put down a list of red lines and demands before going back into executive, of which a cancer strategy wasn't one of them. And that cost our health service. And I'm cross and I'm angry that we've had a lack of delivery, because my house was very sadly affected as a result. So firstly, can you deal with what the consequences were of having no government for 3 years? And then my other questions relate to how is the goal of ending a postcode lottery in terms of wait times and outcomes for specific cancers at the heart of the department's thinking? And will the timetable for delivery of the strategy be regularly reviewed?
Thank you, Deborah. I would say that the last 5 years have been incredibly difficult for all of us, and I mean, I'm simply a civil servant. I see the problems we have in front of us, and the difficulties on planning, for whatever reason, is difficult for us in terms of service delivery. And I mean that COVID is just as much a problem as all other things we have to deal with. The simple fact is that without long-term planning, it is really hard to plan healthcare services, as it's difficult to recruit and do meaningful transformation. And that is something that is difficult for us. We desperately want to improve services, but that would require us to do long-term planning. When it comes to making sure we have equitable services across Northern Ireland, I would say that we really want to improve outcomes. That's a key thing to what's driving us to come into work every day. We want to improve our outcomes. We believe our draft strategy will show a way forward for improving outcomes. We have to accept that some of these things are going to be very difficult. They're going to take years to complete, and we can't make all changes at the same time. We simply don't have the workforce. We don't have the capacity in the system to make all changes simultaneously. That will require some difficult prioritization, but our absolute aim is to improve outcomes in cancer services in Northern Ireland. That is absolutely top of our agenda.
Thank you.
And in terms of, the postcode lottery and a timetable for delivery of the strategy, will that be regularly reviewed?
Yeah, of course. Sorry, apologies for missing that bit. We will have an indicative plan for delivery with the strategy when it's being published or shortly thereafter, and we will review this regularly. As we heard this morning, there will need to be reviews on what we do in the strategy. With new technologies and new ways of doing treatments and new processes, we can't possibly estimate what will look like in 10 years' time in some of these new developments, and we need to be cognizant of that in the delivery of the strategy. But I mean, it's an equitable service across and around. That's an absolute key for us. That there's no discussion that it shouldn't matter where you live. You should have the same level of service quality and same outcomes wherever you are across the whole of Northern Ireland.
Okay, thank you. Pam, go ahead, please.
Thank you, Chair, and can I thank the panel for your attendance and for the work that is ongoing in terms of getting delivery of the strategy off the ground. That is very much appreciated, and I have to agree with some of the commentary around how difficult the last 5 years have been. They have been incredibly difficult, and we understand the reasons for those, the lack of government for 3 years. And indeed COVID, which has been incredibly difficult for everybody, not least staff members. And I too am very aware, even on a personal basis, how difficult it has been for some staff, and that staff have left the system altogether or moved into different roles because of the trauma of COVID, and that's not to be underestimated. So it's for sure a very difficult thing, and it's really important that we try to retain and recruit staff and do all we can to ensure that we keep what staff we have, because they are incredible. But they're not robots; they're human, and we all need to appreciate how difficult the last period of time has been. In terms of the 2022-23. How would the total investment in cancer services differ under a rollover budget and the Sinn Féin draft settlement that we've been looking at, and what assumptions have the department made in this regard? And then my next question was in around what steps have been taken to factor in the actions within the cancer strategy that can be implemented in a cost-neutral way or absorbed into the spending plans of other departments.
Yeah, thank you very much for those things. So around the budget, the planning on the budget is difficult. As you all know, most costs in health service are staff and staff related, and it will take you need a number of months planning to get people in post. It's not something we can do overnight. So if we get the budget agreed on the 31st of March, we couldn't possibly spend the money on the 1st of April because we couldn't get people in post that quickly. We will do all the planning we can to make as many people we can to line up what we can before that. But the longer any settlement is agreed, the delayed, the longer it will take for us to get things in post on the other end. Therefore, we think at this point it'll be difficult to spend significant amount of extra money next year, even if we get the budget settled today, because it will take time to get people in post. We will always do our very best with that, and I'm sure that we will have some budget agreements at some point, which we can work with, and we will do our very, very best can to perform services where we can do it in a cost-neutral way. Even, however, we must remember that even where there's cost-neutral, long-term cost neutral, even cost savings, there's often a cost in the changeover, in the transformation of services, whether that's through training, whether that's through change in management, whether that's to change process, where you're duplicating services during a transition phase. And without additional funding, we can't even do those. So it's very, very difficult, but I can assure you we're doing our very best. We in the strategy work to date, in our drafting work, we have identified those areas where are cost neutral or potential savings, and we're looking at how we can progress those as quickly as we can. But that's all I can say at this point.
Thank you, Tomas. Paul?
And Thomas, probably just worth mentioning as well, Pam, in this year we spent some £7 million of recurrent money for cancer in line with the cancer strategy. That's been some of the things we've need to do in relation to oncology and hematology stabilisation, additional staff, some of the infrastructure that we need and so on in relation to that. And that is in many ways the core of the cancer services, oncology and hematology, notwithstanding that all acute specialties are involved in delivering cancer services, as we know, and a further 3 million we've put in place for cancer trackers for our new QFIT testing, which is avoiding an awful lot of unnecessary endoscopies and so on, which has proved very successful, supported by GPs and primary care. Additional services that we've been able to mainstream that had been part of the transformation programme, such as skin cancer surgery and additional testing and so on. So some things are happening. So to reassure you, the strategy and some of the ideas within the strategy are beginning to be taken forward, but I think we know that we need also a step change in the coming year as well.
Okay, thank you. Paula.
Thank you, Chair. Thank you, panel, for coming this morning. I suppose a lot of the questions I was going to ask have already been asked. So I wanted to focus in on cross-border collaboration. Obviously, there's some really good research going on down in some of the universities in the south, etc. And I'm just wondering, to what degree do you see the rollout of the cancer strategy involving greater cross-border collaboration? That's the first question. And the second question is in relation to diagnosis. My mother had bowel cancer, for example, and one way of detecting that would be through an endoscopy. And I'm just wondering what role will Encompass play in actually trying to identify people to bring forward for early screening, testing, or diagnosis, so that obviously the treatment could be easier. So Encompass and cross-border collaboration, please. Thank you.
Thank you very much, Paula. When it comes to cross-border work, I mean, we're willing to work with anyone who can improve outcomes for cancer patients. We don't really mind where they are. And on that, of course, going forward, we know that with more and more specialities and more with more specialities, we will have to look at more detailed work and more smaller sites potentially. And working with the South, working with England, Scotland, Wales becomes completely natural in that process. We will go with where the expertise is, and we'll also bring as much of it we can to Northern Ireland, of course. But where we can't do that, we'll work with what we can to get that to as close to people as homes as possible. So I mean that is not a barrier for us. When it comes to Diagnose and Encompass, of course, having Encompass as one computer program will be easier to identify people. It will be easier to do anything that has to do with patient notes and files, and the data around that. So that will of course help us in screening people, which will be great help when it comes in.
I see Gay want to come in. Sorry, can I just follow on that and then I'll come back to you, Gay? I'm just wondering with Encompass, will patient records be aligned across family connections even if they're in a different GP practice? Do you know that question?
I don't know off the top of my head. Maybe Paul.
No, I don't know it either, Paula. It's a technical question we would have to test and come back to you on. Apologies.
Okay, Gay, go ahead.
I just add a bit about the cross-border collaboration. You're all aware the North West Cancer Centre both covers patients this side of the border and across, and that's seen pretty much as a success factor moving forward. There's also the All Ireland Cancer Consortium, which was the memorandum was reaffirmed last March by the United States, Ireland and the south of Ireland, and through that we have been developing a lot of research type projects both north and south of the border to take forward. We're also looking at children's oncology services and how we can work with our colleagues in the south to take the lead on that. With regard, just to add a little bit about Encompass, the pandemic has really shed a light on the data, on the gaps of data that we have within, within cancer services. And with regard to Encompass, we will be needing to put in place our kind of minimum data sets and so forth, and our roadmap that will align in with Encompass. So we will be looking at gathering additional data, not only on primary cancers, but also on the secondary cancers and on latent and long-term effects and secondary effects for people who are living with cancer. So that would all then be aligned with Encompass at the appropriate stage.
Okay.
Thank you, Chair.
Okay, yeah, thank you. And just to say in relation to that, and that has come up quite a bit over the past wee while, including at the all-party group recently, Paula, and we are working at looking on getting a briefing from the All-Ireland Cancer Research Institute in terms of the opportunities, and I think there is some real potential there. So we're waiting for a response from the Oireachtas to see how we might arrange a joint committee meeting in relation to potential to explore that area. So that's okay. Listen, I just want to come back again on the issue of workforce, Tomas, and we have heard earlier actually in relation to how staff here are providing some of the most unpaid hours, and that is between staff going above and beyond and carers are essentially propping up the system. We're also in a situation where that 6,500 workforce absentee vacancies, actively being recruited vacancies, is not getting better. In fact, it's getting worse, and we see an additional 600 onto that. And I know there's lots of work going on, but it appears from the outside that there is inertia, and that the staff out there are drowning in a sea of inertia around getting more staff into place. I've raised the issue of the 25,000 applications for the workforce appeal. We're awaiting a department response as to how many of those people could realistically be brought into service. But I want to ask another question, and I'm conscious we're coming towards the end of the mandate, but we are in an escalating workforce crisis. We have to recognise that. And Paul, you had mentioned there that we need to see a step change in coming years. And I want to ask this question for consideration, and something we have to think about. Is the BSO model big enough for this crisis that we're in at present? And does the step change need to include looking at some sort of a task force approach to the workforce vacancy crisis, where we bring in significant focus and expertise to urgently get staff on the ground? Because there is a lead-in time here, and we need to short-circuit it to the greatest extent possible. So BSO was set up to provide continuing ongoing support and workers to the health service. But is this crisis overwhelming them? Do we need to look at a different approach?
So in terms of BSO, I don't think I'm the right person to comment on the effectiveness or not of BSO, and we would have to get back to you on that. When it comes to specifically on cancer workforce, I would say that we will, most likely in the cancer strategy, provide something around immediate workforce pressures and how we look at the cancer workforce to make sure that we are using people right, that we're using alternative workforce as we heard about earlier on, and that we use work people at the top of the band. That will help people to be effective and to feel valued in the work that's happening, and also help with some of the staffing difficulties we have. I mean, the reality as well, though, that even if we wanted to invest, even if we had money to employ workforce tomorrow, there's many areas where we simply can't because the workforce doesn't exist. There aren't an unemployed level of workforce in many areas where we can employ. So therefore we need to think differently how we do things. We can't just keep on doing the same things. We shouldn't just rebuild our services to what they were before the pandemic. We should rebuild them better. And that includes the workforce. There's very much with the workforce, but it's working with the workforce. So it's not dictating from the top. It's working with the workforce how we can get the best outcome and get the best out of staff in a positive way. Of course, I mean that. And I mean, I know we talked about other topics before with yourselves when it comes to the mental health workforce, and you mentioned 123 GP earlier on. That's one area where we can work differently, how we can do things differently, both in cancer services and other services. So it's about using all available tools to us to make sure that we get the best outcome for our cancer patients as possible.
Okay, thank you. And absolutely, I would agree that the workforce and workforce representatives need to be centrally involved in any type of task force or any type of focus that will be being placed on that. That will be a critical part of it. Okay, listen, I want to thank you for your session here today. It's been very important. There are significant areas of concern currently and emerging, and those are things that we cannot simply ignore. So I want to thank the panel. Thank you, Tomas, Gay and Paul, for your attendance and your contribution to the committee this morning. Thank you.
Thank you.
Thank you very much.
Okay, thank you, members. Okay, members. So any thoughts then in relation to that, those two sessions, in relation to the concerns that are being expressed there? Yeah, Carol, go ahead.
Chair, so I suppose I'm thinking back to the presentation I had with Patricia around transformation, and indeed what's been referred to as the Minister's financial settlement, even in these circumstances. But I just can't help but feel that the officials, despite giving as much reassurance and rightly paying tribute to staff, we need to see a bespoke plan around what money the Minister has in this, for the rest of the mandate in these circumstances, what will be done to help those cancer services and indeed the retention of staff. And then the other aspect is just in terms of the red flag stuff, can we get better reassurance from the department?
Yeah, anything else, members? Colin, go ahead.
There we go. Yeah, sure. I mean, would there be any way maybe of just writing about the issue of the preventative side? Because I think the statistic that there is quite stark that by 2040 there's going to be a doubling in the number of cancer cases. And I mean, I don't think that we're going to see a doubling of the capacity within our cancer services to treat that. So I take the point that we really need to be looking at, interventions to try and prevent people from getting cancer. So is there a way that we could even just at this stage of the mandate just write to the department and ask them how that is actually being included in the strategy and how it will be sort of amplified given those statistics?
Yeah, content. Is that something that we can do? Yep. Content. Members content with that? Yeah. And also content on Carol's suggestion. Could we also, I think, write to ask the department to urgently follow up on that issue of the 25,000 COVID appeal applications? And I reiterate again, those are outstanding applications over and above the ones that have been. Those are formal applications made and not progressed. So I think we'll write to the department and ask them to urgently respond on that matter in terms of a breakdown of what staff potentially are contained within that cohort and how many whole-time equivalents could be drawn from it. Any other thoughts, members, in relation to the information we've just heard? Pam, go ahead.
Yeah, Chair, just in the back of what Colin was saying there, and I think it kind of does take us back to almost to last week and that much weighted briefing that we were waiting for on transformation, and actually the fact that we had one official who was sent to committee with having only been in the role for 2 weeks, and I just think it was incredibly disappointing that the department hasn't treated this particular item more seriously. I do have serious concerns that Colin is right. It's quite clear that the capacity is not going to be there in the future, and it drives home that need, that vital need that we all know about for transformation. But yet we haven't seen transformation. We haven't seen the plan for transformation. And indeed, when we had the brief from the department, it was sorely lacking. And I'm not being personal. The official is an incredibly capable woman, but she's been almost thrown in at the last minute, and I don't think it's really good enough that the department has done that and hasn't appeared to take the item seriously in any way at all, and has really failed to show us any type of plan going forward.
Yep. Okay. Yeah. Some. Carol, go ahead.
Yeah. Sorry, Chair. Yeah, so I raised the issue around the transformation, but I also think we should talk about, we do need to ask what the impact on the budgets will be. I want to see something more specific in that, given the collapse of the executive. I think the quarterly budget, given the pressures that we're under, needs to be better understood. And that needs, in my opinion, that needs to come to the committee. So I would like to see that definitely featured in any correspondence to the department.
Okay, thank you, members, and thank you for that. So listen, I'm going to take a very short break there. What I am going to suggest, members, given the importance of that cancer information that we've been taking this morning, what I may want to do is look at rescheduling potentially some of the SRs where we can, and potentially the correspondence. But I'm going to take a short break now, and if we could come back at 12:05, members, please, we'll try to resume the session then. Thank you.
Senate Chamber, Programme Sound. This is the Northern Ireland Assembly Senate Chamber, Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound. This is the Northern Ireland Assembly Senate Chamber Programme Sound.
Okay, thank you, members. So, members, moving on then to item 8, which is the Hospital Parking Charges Bill, consideration of final report. We will now consider the final draft of the committee's report on this bill. I refer members to a copy of the draft report at tab 8.1 of the table pack, and we will consider each section in turn. I will ask the clerk then to comment on the report, please.
Thanks, Chair. Just to highlight, when we put it into this format, we've seen a couple of wee issues around formatting on the contents page of the report, so we'll get that all fixed. So it was just to highlight really that we are aware there's a couple of issues with the contents page, and but the report reflects on what was discussed at last week's meeting, so happy to take any further comments.
Okay. Members, anything for the clerk in relation to that before we go into the section by section? No, I don't think so. Okay. Okay, members, so I will then refer members to the title page, table of contents, committee powers and membership, and the list of abbreviations and acronyms at pages 26 to 30 of the table pack. Are members content with this section as drafted? Yep, thank you. Members are content. I refer members to the executive summary at pages 31 to 32 of the table pack. Are members content with this draft section as drafted? Yeah, content. Thank you, members. I refer members to the introduction and committee approach at paragraphs 1 to 15 at pages 33 to 35 of the table pack. Are members content with that section? Yep, members content. Thank you. I refer members to the consideration of evidence at paragraphs 16 to 59, which are at pages 36 to 46 of the table pack. Are members content with that section as drafted? Members content, thank you. I refer members to the clause-by-clause consideration of the bill at paragraphs 60 to 63 at page 47 of the table pack. Are members content with this section as drafted? Content, thank you. I refer members to the appendices at page 48 of the table pack. Are members content with this section as drafted? Content, thank you. And are members content that the minutes from this meeting are approved by the Chair so that they can be included as part of the report? Members content, thank you. And in terms of publishing the report, I will put the question that the Committee for Health is content for the report on the Hospital Parking Charges Bill to be published. Are we content? Thank you. Yeah, I think of a double up there, yes.
Apologies.
So our members, just finally then, two final items for consideration. Are members content for committee staff to make any necessary formatting changes in advance of electronic publication? Yep, content. Thank you, members. And members, can I seek agreement that we issue a link to the report to the organisations who provided evidence to the committee and to the department? Yep, thank you, members are content. Okay, members, I'm moving on then to some. There are some of the SRs, members, which we have already previously considered taking briefings on, and I will take those SRs. The ones that I'm proposing to defer are ones which would require a briefing, and we will reschedule those with members' agreement. So if members are content, I'll move forward with the ones that we have already discussed. Thank you. So item 9 then is SR 2022/31, the Pharmaceutical Services Amendment Regulations NA 2022. The Department advises that this SR will amend existing pharmaceutical services regulations to make provision for community pharmacy to dispense prescriptions written by therapeutic, radiographer, independent prescribers, paramedic independent prescribers, or dietitian supplementary prescribers. The regulations will also make provisions to support the rapid and effective rollout of a COVID-19 vaccine and the influenza vaccine. Can I remind members that the committee considered the SL1 policy proposal for this SR at a previous meeting and were content that the department make the statutory rule. The committee advises that there have been no changes to policy content since the SL1 was submitted to the committee. The examiner of statutory rules has not raised any issues with the rule. The SR is subject to negative resolution procedure. So do members have any issues they wish to raise in connection with the statutory rule? No, thank you then. Can I ask members to agree formally that the Committee for Health has considered SR 2022/31, the Pharmaceutical Services Amendment Regulations 2022, and has no objection to the rule? Are we agreed? Agreed. Thank you, members. Moving on then to item 10, draft SA, the Human Medicines Amendments relating to the Early Access to Medicine Schemes Regulations 2022. I refer members to tab 10 of your pack. The Department advises that this statutory instrument will amend the Human Medicines Regulations 2012 to regulate for the Early Access to Medicines scheme. Members will recall that the committee received a briefing from the Department on the policy proposal for this statutory instrument at our meeting on the 3rd of February, and we agreed that we were content that the SA be made. The committee asked the Department to provide further information in relation to the EAMS, and the Department's response is contained at tab 10.2 of your table papers. The Department have advised that there have been no changes to policy content since the SL1 was submitted to the committee. So have members any further issues they wish to raise in connection with the statutory instrument? No, thank you, members. Then are members therefore content with the statutory instrument? Yes, members content. Thank you. Item 11 is again a draft SI, and this one is in relation to the Human Medicines Coronavirus and Influenza Amendment Regulations 2022. I refer you, members, to the papers at tab 13 of the pack. This statutory instrument will amend the Human Medicines Regulations 2012, which govern the arrangements for the licensing, manufacture, wholesale dealing and sale or supply of human medicines for human use. Members will recall that the committee was briefed by the Department on the policy proposal for this SI at its meeting on the 27th of January and was agreed that it was content. The committee is advised that there have been no changes to policy content since the SL1 was submitted to the committee. Have members any issues they wish to raise in connection with the statutory instrument? No issues, members. Thank you. Are the members therefore content with the statutory instrument? Yeah, thank you. So, members, the next two SRs then are the ones that I'll reschedule with your agreement, SR 2022/43 and SR 2022/46. We will reschedule a briefing for those members. So that brings us forward then to another SL1, and we're on to now item 15 on your agenda. SL1, which is related to the Health and Social Care Act, NA 2022, Consequential and Miscellaneous Amendment Regulations 2022. So, members, the Department advises that this proposed statutory rule will amend regulations pertaining to dental and ophthalmic primary care provision for the North, consequential to the closure of the Regional Board by the Health and Social Care Act NA 2022. So this is emerging from the closure of the board. It also takes the opportunity to correct historical minor typographical errors. No policy intent is changed in the making of the regulations. Is the committee content that the department go ahead and make the statutory rule? Yeah, content. Thank you, members. Item 16 then, SL1. Again, this one is in relation to the health and personal and social services, medical profession, responsible officers, amendment regulations 2022. The department advises that this SR is technical in nature and is intended to facilitate the establishment of a second responsible officer role within the department. And that is in the context of the introduction of the Health and Social Care NI Bill 2021 and the subsequent closure of the board in March 2022. Responsible officers have responsibility under current regulations to ensure each medical practitioner is up to date and fit to practice across all areas in which they are working and investigate any concerns. The responsible officer for GPs is currently located within the Health and Social Care Board. This SR will allow for the establishment of a second responsible officer post within the department to assume the oversight role for GPs. So are members content that the department makes that statutory rule? Yep, members content, thank you. Okay, members, so I will be able to move to correspondence then, and I propose that we will do that as time does allow. So I'll move to correspondence and draw members' attention to several items. First of all, item 17.2 is a response from the Belfast Trust to an issue raised by Abolish Abortion NI regarding apparent discrepancies in the recording of incidents at the Trust's Sexual and Reproductive Health Clinic. So, do members have any comments in relation to that, and would members be content that we forward the response to Abolish Abortion NI? Members are content. Any other comment? No, thank you. Okay, members are content to forward that response. Thank you. Item 17.3 is from the Ambulance Service Trust, providing a further breakdown of serious adverse incidents over the last 12 months. Do members have any comments in relation to that item? No comments for now. Thank you, members. Item 17.4 is from Stronger Together in relation to access to GP services for newcomer families in particular. And this is an issue that I flagged members a number of weeks ago in relation to right across the north. I'm receiving information that people are significantly and in fact being prevented from accessing GP services as a result of the registration system that's in place. So I think that's a significant issue. I'm also aware that there have been similar issues being raised by dentistry and by people seeking to access dentistry. So I think it's something that we actually need to look at in the round. I think we need to look at maybe getting a briefing from this, maybe from the board or the officials within the board who are currently responsible for GP services to address this, and also the the issue of potential GP closures and the impact that would have on a domino effect right across certain parts of the West. So I wonder, would members be content that we forward this to the department for a response, and also that we look at a briefing from the HSCB in relation to GP services? And any other comments, members? Yeah, Deborah, are you looking in there?
Yeah, thank you, Chair. This was an issue that we talked about at length last week as well, and I am getting increasingly concerned, and even in the last week I've had more information, and I know yourself received more information as well from the GPs in the southwest area. This is going to be a huge issue going forward, and it is going to be a domino effect. We are at a real tipping point here, and we need some action. So certainly any briefings that we can get in the limited time that we have to try and push for some action on this is really, really important. So I would support you, in that as well, Chair. Thank you.
Thank you, Deborah. Pam?
Thanks, Chair. And yes, I'll also back your comments and Deborah's in terms of the GP scenario. And also in terms of dentistry, I think it's really important that because access to dentists is a real problem. But it was more in relation actually to the previous issue, Chair, the serious adverse incidents. And I was going to suggest in terms of NIAS. It was just to suggest that it might be useful for the committee to request an update from the department on the timeframe for considering business case and addressing other factors related to the demands on the ambulance service. So I just think if we could get an update from the department, I think that would be appropriate.
Yeah, members content with that? Yeah, thank you. Okay, members, so we'll forward that on and we will pick up with the clerk in relation to how we move forward on those. Item 17.9 is a copy of a response from the Department of Health to the Committee for Justice in relation to a shortage of social workers. Any comment, members, in relation to that item? So I would be of the view that it doesn't seem to quite chime with what we're hearing. The response from the department doesn't seem to chime with what we're hearing on the ground from Baswa and people like that. And I think it would be useful if we could request a copy of the review to see the more detailed breakdown, because it would appear that social workers and social work is under increasing pressure around vacancies similar to other roles. Carol, were you looking in there?
Yeah, no, Chair, thank you for that, because that doesn't chime at all with the experiences on the ground, and even in relation to social care, well, actually right across the whole social work piece, there are huge challenges and there are huge staff shortages that haven't been filled. So just likewise what I mentioned earlier in transformation, I'd like to see a more detailed response from the department, because it doesn't reflect what we're hearing on the ground.
Yep. Okay, so members content that we would request a copy of the review. Thank you. Item 17.18 then is correspondence from the RCN advising of its recent consultative ballot on the 3% pay award for 2021-22. Now, just to note, members, that we have a briefing with the RCN scheduled for the 24th of March. So would members be content to note that, pending taking the briefing from the Royal College? Yep. Thank you, members. Item 17.20 then is correspondence from the clerk to the Chairperson's Liaison Group, seeking the view of the committee on the CLG report on strengthening committee scrutiny. So I'll ask members for comment, and also, I wonder if members would be content that we note the recommendation of the report, and also to highlight the need for additional resources in the committee teams. We've seen extremely stretched workloads across committee here, particularly in the Committee for Health, over the past period of time. But any other comments on that, members? Carol, go ahead.
Chair, it's just that I'm currently chairing the CLG, so I'd be content if we just noted the report, and certainly I agree with the sentiment you make, but just to have it in a record. I don't think any of us would disagree with better scrutiny at committees at all. I just feel the report is way out of scope of what was originally intended, and I just want to put that in a record.
Okay, so I think I had an indication from Paula. I'll just check. Were you looking in, Paula?
Yeah, just briefly, Chair. No, I read the report. I thought they really captured the pressures that we were feeling here, certainly in the Health Committee, very well, and just to see whether some of this can be factored into the sort of briefing for the next Health Committee going forward, so that they're aware of the pressures that could possibly mount up again in terms of just pacing the workload during the next mandate. Thank you.
Thank you, Paula. Pam, were you looking in on this one?
Yeah, thanks, Chair. I fully agree with Paula's comments there. I think it is important to recognise the difference in pressures across the committees, and health in particular has a severe pressure over the last 2 years, and I think that needs to be recognised in terms of the support that's given behind the scenes, but because it's an incredible support that the committee team and the clerk give to us as members, but it's vital for us, and I know why I've kept talking about ensuring that we have good scrutiny and that we're doing things in a timely fashion, and it is pretty difficult. So that support is very much critical. So I think that needs to be relayed back. Thank you.
Thank you, members. And then, do members have any comments to make in relation to any other items of correspondence? No, thank you. And are members therefore content with the actions on the correspondence memo? Yep, thank you, members. Members, moving on to table papers, a couple of items I'd like to draw members' attention to. At tab 17.24 of the table pack, there's correspondence from the Department advising that a consultation on the introduction of minimum unit pricing for alcohol was launched on 22nd of February, and the consultation will run until the 17th of May 2022. Are members content to note that consultation? Yeah. Okay, thank you. And actually that is the only item I have. Do members have any other further comment on items in the table pack? Paula?
Thank you, Chair. I fully agree about the minimum unit price of alcohol, but I just wanted to acknowledge Royal Mail's letter there about support for women going through the menopause. I thought it was really proactive, really good to see, and it would be amazing if we could see some other large-scale employers and smaller-scale employers taking on a similar initiative. Thank you.
Yep, thank you, Paula. Yeah, and that is work. I think that is important work, and I'm aware that there is significant work going on. Even we're hoping to come forward with some policy around that, but that is a massive issue out there. I agree with you. Okay, members, thank you for that. Moving on then to the Forward Work Programme. I refer members to the Forward Work Programme at tab 18.1 of the tabled papers. Are members content with the Forward Work Programme as outlined? And thank you. And can I remind members that we are holding...
Sorry, Chair.
Yes, was that Deborah? Go ahead, Deborah.
Sorry, Chair. I do just want to put on record, I suppose I'm very disappointed to see that the last meeting of our committee is when the Minister is going to be available. We have quite we've seen this week the pressures and the scale of the health crisis. And, that really gives us no time as a committee afterwards to do anything. And I would just want to express my disappointment that that's the only date that is available. I'm sure there would have been, opportunity, even if there was a special briefing or something like that, and I know that the clerk and yourself have done a lot of work in trying to make sure that there is a date available. But I just do want to put that on record, that I think it is very disappointing that it is the last meeting of our Health Committee. So thank you, Chair.
Yeah, and I think actually it will be appropriate even still to go back to the Department and ask them if anything else has opened up in relation to that, because I agree with you. That it is very late in the day, and it's been quite a while since we have had an opportunity to discuss. But the most important issue, I think, is the one you identified, Deborah, is the ability to follow up and even to include that within our report for an incoming committee. So yeah, I think we should again revisit that and see if it's possible to bring it forward. Fully agree.
Thank you.
Agreed.
Yeah, thanks, Pam. Or Leah, you were hand up there?
Yeah, no, it was just to come in the back of Deborah there. I completely support that request. I think that just given the urgency of the overall health situation at the moment, and because we are coming to the end of the mandate, I would also prefer if we could prioritise that briefing from the Minister. And I also accept that I know that he hasn't been well and stuff, and so it's not to put any undue pressure on him in regards to that, but we have been having additional committee meetings, like on Tuesday afternoons and stuff. So even if there was another day, if the Thursdays didn't suit, but if we could just go back and maybe just ask again to get it a wee bit earlier.
Okay, thank you, members. Thank you for that. And just to remind then, members, we have our stakeholder event in Dungannon, and this is where we're taking an opportunity to try to meet some of the organisations who we have agreed and tried to meet and weren't able largely to meet as a result of pressures of COVID and all of the legislative pressures. But I'll ask the clerk just to outline the programme for the meeting.
Thanks, Chair. Just to outline that the plan is we're meeting at the junction in Dungannon. There'll be tea and coffee available from 9:30 with the first briefing due to start at 10. We're still finalising the programme, but it's with organisations such as Brain Injury Matters, Focus Identity Trust, Action Mental Health, Chasney, Care Home Advice and Support. So we're just finalising the details for that. But the meeting will take place from around 10 o'clock through to around 12.
Yep. Okay, and I look forward to welcoming members to our lovely part of the world, and hopefully we'll have a snow-free motorway for you all to travel up, contra to the one that I had to travel this way this morning. So thanks for that, members. I think that's going to be a really great engagement with some of those very important organisations. I would also remind members that we are meeting concurrently with the Justice Committee today at 1 p.m. So, members, any other business? No other business. Thank you, members.
Chairman, could I
Yes, go ahead, Alan. Yep, go ahead.
I have raised my hand there, Chairman, during the discussion about bringing the Minister to the committee. I would like to put it on record that I don't think that we've had any history of the Minister refusing to accommodate us or come to our meetings. In fact, I think if a check of the records would show that he's the Minister with the most attendances at his statutory committee. So I think that if we do ask the Health Minister to come before us, I think we'll be pushing at an open door, and I think that he hasn't failed to accommodate us in the past, and I'm sure he'll not turn us down on this occasion. Thank you, Mr. Chairman.
Thank you, Alan. That's a very well made point, and we do acknowledge that you have been very supportive of the Minister, and indeed the Minister has been with us on quite a few occasions. This time, the particular issue is around the fact that it's the final meeting of the committee, and that would be very late in the day. So, in keeping with what you have said, Alan, I would certainly hope that the Minister will continue to be flexible and to prioritise that request from the committee. Thank you. Members, then, there being no other business, then I'm going to go to date, time and place of our next meeting, which will be at 12:45 on Tuesday, the 1st of March, in room 30. Thank you, members, and I'll see you all again soon. Thank you.
This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound. This is the Northern Ireland Assembly Senate Chamber programme sound.